Thank you for your patience as we tried to allow some of the other folks that have registered for this evening's presentation to join us. But first of all, let me introduce myself. My name is Howard Rosenthal, and I'm the Associate Director of your Jewish Federation of Fort Worth and Tarrant County. It's my pleasure to serve in that capacity. And I want to thank you ever so much for joining us for what, as I said, I believe will be a very interesting presentation. And for joining us for the annual Kornbleet Scholar Lecture, which is we've been very fortunate to have available over quite a number of years now. So thank you again for joining. This year's Scholar Lecture features two well-known local doctors, Dr. Murray Cohen and Dr. Sam Kleinman. It's made possible by the support of our Jewish Federation, the Kornbleet Scholar Fund of the Jewish Federation Foundation, and also a grant from the Dan Dinsiger Fort Worth Hebrew Day School or Day School Supporting Foundation. This is different than some of the Zooms that many of you have been on. This is actually a Zoom webinar, and that is due to the number of people that are signed up for the presentation. I point that out only because, in contrast to the Zooms that you've been on many times over the last 7 months or so, the only folks who will be visible on the screen will be the presenters. So you will not have the gallery view or be seeing other folks who are participants in the program tonight. We think that the program should last somewhere around 50 minutes. And we're going to try, we hope to leave around 15 minutes thereafter for your questions. In regard to questions, you will notice, and you're probably familiar with this from other Zooms that you may have been on, there is a chat function at the bottom of your screen, and you can click on that, and we'd love to have you provide us with the questions that you have after listening to Drs. Cohen and Kleinman. Please try to keep your questions focused on the topic of the evening, and we would really appreciate that we all try to avoid, particularly at this time, any political questions or observations, things with political overtones. So we would appreciate that each one of us put that in our back pocket and leave it behind us for this hour. So let me try to introduce our speakers. Dr. Murray Cohen is basically a native son of the community of Fort Worth. He graduated from Westcliff Elementary, which is great. I don't remember graduating from elementary school, but I guess those that are of renown actually get some kind of a diploma and actually graduate from elementary school. So congratulations to Murray for that. But also he went on to McLean Middle School and Pascal High School following that in Fort Worth. He earned degrees in microbiology and community health from the University of Texas, PhD in environmental and occupational health sciences from the University of Illinois Chicago Medical School or Medical Center. Dr. Cohen served 21 years with the CDC, which we all are familiar with over these recent months. He was a U.S. Public Health Service officer, and then 10 years following that with the National Institutes of Health and the World Health Organization. Dr. Cohen is an internationally recognized expert in laboratory, hospital safety and health, and biosecurity, specializing in occupationally transmitted infectious diseases, bioterrorism, and emerging pathogens. Dr. Cohen is going to provide us with not only an update of what we do know, but at least personally, I think what may be of great interest to many of you, it is to me, what we do not know about the coronavirus. So we'll be hearing about that from Dr. Cohen as well. Following that, we're going to hear from Dr. Sam Kleinman. Sam is from the metropolitan area of Richmond, Texas. Population at that time around 300, and comes by his current occupation well. His father was a family physician there in the Richmond area. He attended Texas A&M, received a degree in finance, and why he didn't stay in finance and went back into medicine, I don't know, but he made that decision. He went to Rice and the University of Houston to do some part-time studying of pre-med courses, following which he went on to Texas Tech University and graduated there from their School of Medicine. Split time on his residency between Texas Tech and Emory University in Atlanta. He then completed a fellowship in pediatric anesthesia at the Hospital for Sick Children in Toronto, where he met his wife, Diane, many of us know, and Sam, for whatever reason, insisted that I mention to you that a wife being the only thing that one can actually bring back from Canada without paying some type of customs duty. So they met in Toronto and certainly now residing in Fort Worth. Sam returned after coming back from Canada to Texas Tech as an assistant professor specializing in anesthesia for pediatric, cardiac, and liver transplant surgery. He later moved to El Paso and was later recruited to Cook's Children in Fort Worth. He was appointed to as the medical director of surgical services and chief of anesthesia, and held that position for 11 years before stepping down in 2012 to join the the Heart Center team at Cook, and to devote his time to his first love, which was caring for pediatric and adult patients with congenital heart disease. Sam became infected with the COVID-19 virus earlier, this summer, and has graciously agreed to speak with us about his experiences, and we look forward to hearing those as well. So without further ado, I want to turn the presentation over first to Dr. Cohen, and we look forward to the presentations.
Thank you very much, Howard, for the kind introduction. I'd like to take this opportunity to thank Bob for all you've brought to this community in your years here. We're going to miss you. We certainly wish you, Kim, and Lily all the best in your next adventures in Iowa. I also want to mention to the community what a special privilege it is for me to give this year's Kornbleet Scholar Lecture. I grew up 3 doors down from the Kornbleet family, and in fact, Marcia gave me my very first payday as a babysitter for Nan and Laura. So this feels especially close to me. As Howard told you, I'm going to talk about some things that you know or should know about the COVID-19 virus. I'll point out things that we still don't know, even 10 months into this pandemic. And then I'm going to turn it over to Dr. Sam Kleinman, who will provide a testimonial as a survivor of this very serious COVID-19 infection, as well as tell you about probably the most curious aspect that's unknown about this virus, and that's its effect in children. First of all, we know that this is a really nasty virus. This is the real deal. This is a science fiction novel type of plague on mankind. The virus is highly contagious through a number of routes of exposure. It's not just a respiratory virus. Even though that's the principal route of transmission, the virus also attacks the heart, kidneys, vascular system, central nervous system, and we're still learning more surprises. We don't know what the long-lasting effects and sequelae will be, but it's clear this is not a case of whatever doesn't kill you makes you stronger. Last Friday, we recorded 85,000 new cases. which is a new high for a daily count in the United States. There are also over 220,000 deaths from this virus in the US since January, and that is likely a gross undercount. US hospitalizations increased 40% in the last month. We're now operating near capacity in many of the nation's hospitals. The number of cases per state correlates almost perfectly with the lack of mask wearing. And we'll have more about that in a bit. I'm not making a political statement. I'm making a medical statement. These people who refuse to wear masks for any reason are just being selfish. And they are the reason the virus is winning. We're coming into flu season now, expecting what we call the twin-demic of flu and COVID-19 at the same time. Meanwhile, Europe, which had largely contained the virus, is now suffering through a new wave. Italy and Spain have pretty much shut down to try to halt raging transmission in their countries. Some good news is that we're making great progress in developing treatments as well as vaccines. I'll talk more about vaccines in a minute, but for now, our only real defense is prevention. It's just us against the virus. We know that masks work. We know that any mask is our best level of protection now, other than complete isolation from being around other people. Some face coverings work better than others, but any face covering will provide some measure of protection for you and everyone around you. Aerosol transmission versus droplet transmission, this is very confusing, and it's very much misunderstood still. The general public, I recommend that you just think of the transmission risk as shared air. It's not clouds of virus lurking around, floating from place to place, just waiting for you to walk through it. These tiny aerosol droplets of virus dissipate, dry, and die rapidly. And you don't need to understand the aerosol physics to understand that face covering, physical distancing, and staying out of low ventilation, low ceiling, crowded indoor places is the way to protect yourself. We know now that we don't need to perseverate about wiping everything down with germicides, because although the virus might remain on surfaces, the only way for it to infect us is to touch it and then touch your mouth, eyes, or nose to get it into your respiratory system. Consequently, diligence with hand hygiene is the way to prevent exposures from viruses on surface, not copious use of germicides. Even if you pick up the virus on your hands, you wash it away before touching your face with simple soap and water, or an antimicrobial gel. I'd like to emphasize on this point that there's no need for anxiety attacks whenever the media makes some breaking news report, such as an esoteric study at a university somewhere that demonstrates how long scientists could make the virus remain viable on various surfaces in the laboratory. I call nervous response to such reports CNN-itis. I promised to talk a bit about vaccines because I don't want you to have unreasonable expectations. There's no magic bullet here. It's not just around the corner. Although we will have some vaccines approved probably very soon, possibly by Thanksgiving, certainly by New Year's. But you have to understand that there are many vaccines of many platforms that will work with varying populations. For example, some will work only for people over 55. Others will only work in kids. They'll all be very specific. And we learn that when we go through our 3 phases of clinical trials. As of yesterday, the WHO lists 172 countries around the world currently working some level of vaccine trials. And they project an ambitious 2-year time frame for implementing worldwide vaccination. Everyone on Earth is susceptible, except possibly those survivors of the infection. But we don't yet know for sure that you can't get reinfected. We do know that COVID-19 reinfection so far is pretty rare. We don't know yet how much immunity will actually be conferred even from safe, effective vaccines. For example, it may be like the flu vaccine, where you have to get a new one every year, or maybe like the smallpox vaccine that you get once in a lifetime. Or it could be where you have to get a booster shot every so many years, like tetanus. We just don't know yet. Vaccine production, distribution, and implementation may end up being a bit like the Wild West, with many competing approved vaccines and decisions about who will get the vaccines first, and so on down the line. If you saw the movie Contagion, which I don't recommend for a variety of reasons, but if you did see it, one of the subplots was the Chinese dumping millions of counterfeit vaccines around the globe. I fully expect that to happen. It may already be happening, since the Chinese are widely distributing an as yet unapproved vaccine product to places that we've watched but haven't been able to fully trace yet. So even once we have vaccines, we're still going to have to learn to live with the SARS-2 coronavirus 2019 virus. I think it's fair to say that there's a fairly low health literacy in the public at large, coupled with a very low esteem in which scientists and politicians are held. No vaccine can fix this. The virus is going to be here forever, just like flu or RSV or norovirus. We're going to have to learn to live with it better, to respect it more. Those at higher and higher risk must be extra vigilant. If you don't know who you are, then you haven't been paying enough attention. It's over age 65, pre-existing medical conditions, especially asthma, hypertension, diabetes, heart disease, kidney disease, and those immunocompromised due to medications, chemotherapy, autoimmune diseases, or HIV. We're going to be wearing masks for a long time. We're going to need to be vigilant about hand hygiene and teach that good health practice to our kids. Handshakes and public embraces are gone for a long, long, long time. I was privileged to be working at the WHO headquarters in Geneva on March 3rd, 2003, when the initial reports of the new SARS coronavirus infection started coming in. Just like with SARS-2, that virus originated in China. The Chinese tried to hide it from the world rather than engage a global response. And at the time, there was a lot of hand-wringing about whether this was a Saddam Hussein bioweapon or a naturally occurring spillover event from one mammal to man. We quickly learned its natural origin was in bats. Its spread was by sloppy lapses in laboratory biosafety where specimens from sick people were studied. We learned its extreme contagiousness and the epidemiology of where and how the virus was spreading. It was amazing for me to be a part of that cooperative global response led by the WHO. That epidemic was held to 8,100 cases worldwide and fewer than 800 deaths. We have the know-how and the ability to master these viruses, which will keep coming at us, guaranteed. But we have to have the will as humankind to fight back. Now, Sam, please give us your testimonial of your personal COVID experience, and also let us know as a pediatrician, what are the best recommendations for our kids and grandkids? Thank you all very much.
I want to tell everyone how humbled I am to be included in the Kornbleet lecture. And I don't have the curriculum vitae that Murray does. He's a fabulous speaker and so well known in his field. I was asked by Jim that we worry about in terms of children and the virus. Jim said kind of there's 74 participants here, and kind of keep this as if it was a conversation. As if you asked me what it was like to have COVID. And so I may have to refer to a few notes because it's what those of us who have been through it, it's called COVID head. You don't really remember when you're really sick, all the events happen in what sequence. So although my CV is not impressive, it's unfortunate that if I had died from this and then come back to tell you how it was, then it would have been a pretty impressive thing. But short of that, hopefully I'll tell you something that's a little bit informative. So how did I get COVID? I don't really know. Been very strict since this started, particularly at work in our environment. We're wearing personal protective equipment. No people that I know around me had virus except for working in the operating room. There was one nurse who was suspicious that she'd been exposed. She got tested. She did come to work during that time and eventually tested positive. So it's a possibility that I got it working across an operating table with another nurse. Could I have gotten it from a patient? It's probable, it's possible. Kids don't seem to spread this the way adults do, but there is one study that looked at individuals who intubate patients, which is what I do for a living, and who are COVID patients. And they reported that there's a 10.7% chance of contracting COVID if you do this routinely. So kind of puts a target on those of us that do this kind of work. So how did I know that I got COVID? Well, I didn't. It started on Saturday, June the 20th, and I had a wonderful day. My son had just been called back to the U.S. Naval Academy, was here for spring break, and we kind of spent the day together, and about to go to bed. It was 11 o'clock, and I suddenly noticed that I was getting the sniffles, and I thought, well, I'm that atopic kid that's had a runny nose since I was born, and I thought I was just getting some allergies and just clearing my throat and coughing a bit. Sunday was equal. It was the same. I didn't feel bad, had no fever, no symptoms. Monday, I went to work as normal, as usual. And then about 1 p.m, my son, who had was put on the plane on Sunday back to the U.S. Naval Academy, called and said, "Dad, I tested positive. And if you want to spread panic through a hospital, just go down, just call the infectious disease control people and tell them that you're a physician and you've been with your son and you may have some very mild early symptoms now in retrospect, and he is positive for coronavirus." They dragged me to the to the emergency room immediately, gave me a rapid test where I tested positive. I still didn't feel bad for a couple of days, and then I started getting muscle aches, myalgias, and my son, talking to him, had exactly the same symptoms. He had very little fever, but over time I started to develop fever. I developed headaches. These myalgias, or sort of muscle aches, were mostly kind of limb-girdle. They were like my hips, my back, my shoulders. The headache was kind of nagging. It wasn't terrible. The fevers would go into the 101. Occasionally, I think I hit 102. You felt sort of like this was going to be a normal bad flu. Then the myalgias, or the muscle pains, progressed to my extraocular muscles. So those muscles that allow you to look left and right. Every time I would turn my eyes left or right, it was very painful. And I thought, this is not going to be good. And then the shortness of breath started. I wasn't tachypnic or breathing fast, but I felt like I could never get to the top of my breath, like I could never get that full, deep sigh. And then the cough, and the cough was unrelenting. I called one of my friends and he said, "Hey, you're an anesthesiologist, get a pulse oximeter." And I thought, that's how we test oxygen levels and blood oxygen saturation in patients every day. And because I guess I don't get out of the operating room much, I didn't realize that I knew that you could buy them over the counter. I figured they were kind of expensive. And he said, "Hey, dummy, go on Amazon. They're $20 to $30 a piece, and get one Prime like tomorrow." So for those who don't know what that is, I brought one with me, and it's a little device, pretty simple. You clip it on your finger, and it will give you a saturation. In a second, it will give you a reasonably accurate heart rate. Probably says that because I'm talking, I should say 98. It looks a little backwards to me in the screen. And it will give you a rough idea of your saturation. They're not exceptionally accurate, but they are very good at trends. So I got one, but being the scientist that I am, I had to buy at least two to see whether they were that accurate. One worked and the other did, whether they were comparative. And they do give you a good trend. So I followed my saturations, and if I would do deep breaths, my saturations started in the first few days, they were 99, 98, 97. Pretty soon they were 95. If I did some deep breaths, I could get it up. Pretty soon they were down in 92, 93, and sort of hung there unless I was going up and down the stairs, and where it would briefly drop into the 80s. The criteria for admission these days is somewhere in the low 90s and with other symptomatology. So I thought, I'm kind of clipping the treetops here, and we're just going to hang on and see what happens. Then the worst part started, and that was the fatigue. So here you are coughing, short of breath, and it's the most intense fatigue I've ever experienced in my life. I felt like I had gone through the battlefield every day, all day, with a 100-pound pack on my back. You simply didn't care that you were coughing and couldn't breathe. I lay in bed and I would sleep, and then when I woke up, my wife would try to come up in her. I was living upstairs at this time. We sequestered ourselves in the house, and she would come up in her complete hazmat and deliver some food to me, and I would fall asleep on the sofa. It's really fascinating that a virus like this can induce such intense fatigue. Then I started, because you want to sleep all the time, then I developed a symptom called allodynia, and that's a fancy word for extra sensitive skin, so that even light touch to your skin is uncomfortable. And so it almost felt like my skin had a light sunburn. And so you're trying to get comfortable, but all you really want to do is sleep, but you can't get comfortable. And then I started noticing that when I did get up, I started to lose my balance. I felt like I was listing a little bit to the side when I was walking. And then the hoarseness started. And as you can hear today, 4 months out, I still have some degree of hoarseness. My fevers continued on until about the 6th of July. So I assume that's about 16 days, so over 2 weeks. And then the fever subsided. I had a few sweats and chills during that period of time, not many. And then I developed cold sweats, which was very unusual. You could set your watch to it at 3:40 in the morning. I would wake up and the bed sheets were soaked. My clothes were soaked. I would get up, change the bed sheets, change clothes, go back to sleep. Occasionally it would happen again. And so I started calling other doctor friends saying, what is this? And they would say, I have no clue. It's COVID. Nobody really knows, which is not very helpful and encouraging. And then I began to realize that everyone has endogenous or internal cycle of steroids. We call it cortisol. And most people reach their low point. It's cyclical, and they reach their low point in the very early hours. And for me, I figured that's probably at 3:40, that my endogenous steroid level that I need to keep me going was low. And so I would break into these cold sweats. And so that scared me a little bit, thinking that, this is what you see in people who are really highly stressed, ICU patients, and need supplemental steroids. About that time, the cough was persisting. I was starting to get some broken blood vessels. I was coughing so hard around my eyes. And a good friend of mine happened to call, and I didn't know that I was sick. And he's a really great pediatric pulmonologist who was working in Connecticut that I went to medical school with. And his words were, start steroids today, like now. I said, I'll get a prescription tomorrow. No, he said, now. And he said, use an inhaled steroid. And so I started on what we call Pulmicort. It's a budesonide. And I said, well, the usual maximum adult dose is 2 puffs twice a day. He said, start with 10 puffs. So he's a lot smarter in this pulmonary stuff than I am. So I started with 10 puffs, and miraculously, within 24 hours, and I stayed on that for 10 days straight, my cough subsided dramatically. And then 2 more days, the cough was gone. The shortness of breath did not. And he told me that in his patients, and in his older pediatric patients, like in their 20s, he said, this will go on for months. You'll have good days and bad days, and expect that you will look back and see some progress, that you've progressed, but on a daily basis, you won't. Expect to have shortness of breath and those sorts of symptoms for months and months. And he was exactly correct. The interesting thing about when I finally my head was clear and I wasn't as fatigued, I started reading like crazy. I wanted to know where I was going with this. One of the things that I did early on, it's amazing how many studies came out in such a short period of time. I think Murray will probably tell you that from a research standpoint, his head was about to explode. Every day there was a new study about COVID from all corners of the globe. This is a pandemic, and there are smart doctors all over. And so when I called my own physician, they basically said, take vitamin C, take some zinc, and if you get really sick, go to the hospital. If it wasn't getting better, called my doctor again, spoke to the nurse practitioner. I couldn't get through to the doctor. So being a physician doesn't always get you better care. They said, take some zinc, take some vitamin C. If you really get sick, go to the hospital. Eventually, my wife forced me to go to the hospital, where I got some labs that were, most of them were normal. The one that was concerning to me was called ferritin. It's a protein in the body that binds iron. And the normal level is 0 to about 250 in adults. Mine was about 1,300, which is a marker for a poor, when they get that high, it's a marker for poor outcome in this disease. So that shook me up a little bit. And looking at my chest x-ray, it's bad to be able to read your own chest x-ray, but I had pulmonary infiltrates in my lower lobes and my right middle lobe. And it's interesting that when I read the radiologist's review of it, he said, basically, this is COVID, that the findings, the way this disease starts in the lung is so consistent and pathognomonic that the diagnosis can be made that way. There was an interesting study out of China where they did CT scans on patients coming in, didn't tell the radiologist what the diagnosis was, and they had a 97% rate of correct diagnosis of COVID without seeing the laboratory test results. So it scared me a bit. At that point, just prior to that, reading a lot of articles, I started myself on some doxycycline. Why doxycycline? It's a very safe drug. Probably 40 million teenagers with acne take it every day. A very safe, good safety profile. But in India, they've done some studies with it, along with ivermectin. And it has the potential to lower interleukin-6 levels, which are a moderator for an inflammatory response. So at this point, it was, maybe my lungs will get through this, but if I get cytokine storm, this is going to be a really bad thing. I'm going to wind up on a ventilator in an ICU. So I took it. Did it help? I don't know. I stayed out of the hospital. I managed to, like I say, clip the treetops and get through it. And the other thing about doxycycline is interesting that it works a little bit against dengue fever. Murray could probably tell you a little bit about that. And it's a messenger RNA type virus. And so maybe there's something there to it. But I took that. I took high doses of zinc. And we can talk at the end if you want about some of the things that you can take at home that are recommended, things we have some data about, things that we don't, things that might help, things that might not, things that couldn't hurt you. And we can do that a little bit at the end. So slowly I progressed. And today I went back to work after a month, which I hadn't. I was so exhausted every day for the first couple of weeks that I would come home, collapse, and sleep until the alarm went off the next morning. Probably should have stayed out a few more weeks. At 12 weeks, I thought my lungs were improving. I've been on a reduced dose of steroid inhaler every day. And I was told by the pulmonologist, you can't even start weaning until Halloween is coming up. And given the flu season coming up, maybe don't wean too fast. So at 12 weeks, I started jogging. I think my neighbors were looking at me in distress that I would go out and run for about 3 minutes and then take about 2 minutes huffing and puffing, trying to catch my breath. But it's getting a little bit better now. As you can hear, my hoarseness still hasn't resolved. One of the things that did concern me was about the time I was recovering. There was a paper out of Germany looking at asymptomatic individuals who had either been hospitalized or were at home and had survived COVID, who were back to their normal activities. These were people who were running and skiing and doing those sorts of things. And they did cardiac MRIs on them and saw a very high level of inflammation in their hearts. And they had what we call a troponin leak, which is a test that tells us that there's evidence of myocardial injury. And that occurred in 75% of people who were supposedly asymptomatic, and they had a decreased ability of their heart to eject blood by this test. Now, that caused a big flurry of activity and a lot of fear among people, me included. I did get an echocardiogram to see that my function was good. Thank you to the cardiologist. But subsequently, that paper has been retracted a bit, revised statistics. I don't think it's as dire as it really was, but it gives us pause to think about what will be the long-term effects of this disease. As we know, it wasn't really a paper, it was a kind of a letter to the editor that caused a furor among football players at one of the universities, because they showed that these athletes had some degree of inflammation if they'd had COVID before in their heart, and it was very concerning. Of course, there was no control, so we don't really know if doing strenuous activity may, precipitate that too. But it all gives us pause to think that these effects may be more long-lasting than we think. We don't know what the recovery is. We don't really know what the treatment is. We have some ideas and some directions to go with some fairly benign treatments if people are suffering from poor heart function from COVID. But it's the great unknown. We're going to know a lot more a year from now. We're going to know a lot more in retrospect about what does and what doesn't work. So I made it through. I survived. Scared the hell out of my wife. I can tell you, she lost a lot of weight because I think she was nervous and wouldn't eat when I was eating. And so I guess now we'll skip to, I guess we're kind of running short on time. I don't know. Am I doing okay, Bob? And I talk a little bit about kids. So I work at a children's hospital. When COVID-19 came out, we were scared as hell. I have to tell you that. If we'd lived through swine flu was a disease that infected about, Murray might correct me, about 60 million people. We had, it was devastating to children. In the ICU, we had so many kids day after day on life support. It was very depressing. And it was if you were over 65, it really was not a bad disease for you. This is the exact opposite, as it turned out. So lucky for us, we don't see that many children who are have really gotten ill. This is a disease where most children are fairly asymptomatic, have very mild symptoms. I think the evidence is coming out that children, particularly young children below the age of 10 to 12, really don't spread this disease as much as people thought we did, that most of the kids we're seeing and the ones that we're tracing are getting it from adults. It's going adult to child, not so much child to adult, and not so much from child to child, as you've seen that it's been fairly safe, appears to be, to put kids back in school, which has been a very positive thing from the pediatric standpoint. The one thing that we are concerned about is something that is very rare and very concerning, and it's called multisystem inflammatory syndrome. What is it? It occurs in kids. We've seen it from kids under the age of 1 all the way to age 20, mostly in kids 1 to 14 years of age. The peak is about 8 years of age. And these kids present usually about 98% have either been exposed or tested positive for COVID. And they usually present with severe symptoms several weeks, 2 to 4 weeks often, after they've had the disease. So it's a delayed reaction to this. So it's probably an immune inflammatory response. It's called multisystem inflammatory syndrome, simply because it affects multiple organs, excuse me. And basically the CDC's criteria is it has to infect 2 or more organs. So we're talking about heart, we're talking about liver, we're talking about kidneys, we're talking about the neurologic and the hematologic systems, we're talking about skin, those sorts of things. How do these kids present? Oftentimes they come in, and even those with COVID who are symptomatic often present first, primarily with GI symptoms. They come in with vomiting, diarrhea, abdominal discomfort. We see kids with skin rashes, those kinds of things, skin lesions, but this will progress all the way to kids we're seeing in hypotension and shock. Now, very, very, very few kids get COVID and are going to die from it. Like something on the order of, you have a 99.99% chance of being a young child and getting through this without any problem. That said, we've seen about, in all the states combined, almost 1,100 cases of this, about 30 something in Texas. We've seen a number of them at Cook Children's. We've been very, very fortunate that we've had 0 deaths at Cook's. What is this disease? So how do you diagnose it? So a kid comes in with these vague complaints, really don't know exactly what they are. We get laboratory tests and we look at their inflammatory markers. So if these tests show elevations of things that we think are consistent with inflammation, things like C-reactive protein, those sorts of things, it's kind of very esoteric, this conversation, but we look at it and we have no idea why this is happening. It's sort of a diagnosis of exclusion when we see hyperinflammation. So there have been about almost 1,100 cases. There have been 20 deaths. So in the great world of all the children who've been infected, it's a very small number, but it's very concerning. You know, for those of us who work with this, life of every child is very important to us. It is not like swine flu was, where we lost a lot of kids. So we're optimistic, but we don't know what the long-lasting effects are, particularly long-lasting cardiac effects in these kids. So while it doesn't really affect kids much, there is a subset of children who can get very, very ill from this. So how do you protect your kids? It's a really good question. I think that you do exactly what Murray says. Wear a mask, social distance. Yeah, we used to say that the solution to pollution is dilution. If you can put some air distance between you and someone else, the your risk, and wear a mask, the risk of you getting a significant viral load into one of your mucous membranes is going to be low. The problem with one of the problems, you probably agree with me, is that because so many young people have such low symptomatology and it's benign disease, that it makes spreading very complicated. If you're 18 or 19 and younger, like I said, you have about a 99.99% chance of surviving it. If you're 19 to 24, you have a 99.98% chance of surviving it. So if you're a college student, like my niece who went to college and contracted COVID in the first few days at the first illicit party in the dormitory, you are going to contract this disease and have the potential to spread it. And when you think you're young and you think you're invincible, it's tough to control that. They don't feel like it's going to hurt them. They're going to go out, they're going to party, they will spread the disease to the most vulnerable, which are those who have coexisting diseases. Not just the elderly, it's particularly those people with coexisting diseases. So how do you protect your children? I think that this has been a double-edged sword for pediatrics and the pediatricians, because staying at home has caused a lot of problems. We at Cook Children's have seen the number of suicide attempts double. We've seen some actual suicides. We see a lot of depression. We've seen an increase in child abuse. And so those sort of sequelae of lockdown are probably going to turn out to be worse, but it has to be weighed against their ability to spread the disease. And so dealing with children in the era of COVID is a very difficult situation. Like I said before, it seems pretty safe to send kids back to school, and I think that's pretty much been the stand of the American Academy of Pediatrics to get these kids back socializing, and so that we don't have other issues with them. I don't know, how are we doing on time, Bob? Are we good, or do we need to take some questions? Or
Howard, let me turn it over to you, and thank you, Sam. Howard, you need to unmute.
There we go. First, I want to thank both Murray and Sam. I can't thank them enough for taking time to educate us this evening. It's been just enlightening, and I hope that those of you who have tuned in this evening feel the same. I think it's been a great program up to this point, and I know the question and answer are going to be even better. In that regard, please go to the chat at the bottom of your screen, and don't hesitate to drop a question there, and we'll try to pick it up. We do have a question from Rabbi Charlie, one of our local rabbis, and it's a one that we've talked about in the past, and it's a good question. It goes like this: can we learn more about singing indoors versus singing outdoors? Is there a safer distance? How many people at a gathering is too many if there is singing going on? If either of you would have a thought on that. Murray, looks like you do.
or you want to take it, or I'll take it?
Go, well, either or both. Go ahead, Sam. Go ahead, Sam.
There's been a big debate about whether this virus is aerosol or not. And my feeling is it is. Can you get it by droplets? Sure. If you're that close to somebody, you can. The thing about it is, I think there's been a lot of misinformation. I'm an anesthesiologist. I don't do neurosurgery. I don't ask doctors about aerosol science. The best place to find out about aerosol science are people who are PhDs who do this every single day and can tell you about aerosols. I know there are crazy videos that say that these 1 to 10 micron droplets, the virus is 0.12 microns across. I think it's about right. Murray, we can tell you be better. And they coalesce in droplets, and then they're going to go 6 feet and they're going to fall to the ground. Well, if that was true, then the air would be clear because pollution would fall to the ground because it's bigger than that. My allergies would be much better because 50 and 100 micron size Western cedar probably wouldn't blow through. And Saudi Arabia would not have just come through in a giant dust storm recently. So yes, this probably can spread by aerosol transmission. And when you look at, I think one of the things when Rabbi Charlie was talking about singing was one of the things that sort of clued people in was there was, a famous case where people were together and they were singing and they were a very serious choir and people singing on one end seemed to give it to people sitting on the other who had no other communication with them during this event. And so, yes, I think it can be aerosolized. But I think what we're learning now is that what matters is how much, as Murray said, how much air there really is, how often the air turns over, how much volume of air is between you and them. If you're in a room with a lot of recirculated air, not a good place to be. Go outdoors and sing and keep your distance, I think is probably the best thing. I know it's winter, Rabbi. It's probably not going to be a lot of fun to be outside singing, but I think that that distance is really what, and wearing a mask is really what's going to make a difference. I agree with Murray. Masks are a great thing, and I think that masks, beyond what they do, they're really a reminder to everybody that this is a serious thing and that we need to keep our distance, and we need to be cautious about what we do. There are studies all over the place about whether gaiters are good and gaiters are bad, and you should wear surgical mask. And I agree with Murray, any mask is probably better than no mask. There are some fascinating studies about, and they're working with the aerodynamics of masks. The Chinese did a very small study. They had patients who had active COVID. They coughed into a petri dish. They cultured it. Duh. The petri dish had COVID. They coughed into a surgical mask. They took the masks off. They cultured the inside and the outside of the mask. The outside of the mask cultured positive. The inside of the mask didn't. So there's a lot of things about masks that we really don't know. It's a very small study. So there's studies in every direction, and there's a lot of confusion. There's probably one of the things I found most interesting was recently reported was a hospital that mandated not only masks but eye shields within the hospital after they had a fair number of their people working in the hospital getting COVID who were working there, healthcare workers. They said, that's it. We're all going to wear masks and we're all going to wear face shields with it because that protects your mucous membranes of your eyes, particularly working closely with patients. And they're reporting now that they've dropped their infection rate of their healthcare workers almost to zero, and that the number of people seeming to get COVID while hospitalized has dropped dramatically. So I think that it's compelling that masks work and may not work perfectly in every situation. And if you're 100 yards away from somebody on a football field and you're yelling at them from the other end, mask is not going to help you. But in our day-to-day living, I think it's important, and I agree with Murray.
To the question, and maybe Murray can contribute on this as well. Thank you very much, Sam, on that enlightening. Thank you. But if you had let's say you were in a religious service and you had a cantor or someone is singing on the bema, would it be wise to have more of a distance between those in the front row if you were having an in-person service, because there is someone singing in front of you there? Murray, any thought on that?
Yes, wear a mask. One of the points of the whole thing about 6 feet has to do with the aerodynamics of particles of that size, how far they float based on talking. Coughing or sneezing makes them go further. Singing makes them go further still. So it's a matter of understanding. You don't need to know the physics of it, but understand what's happening so that if you're going to be singing, you need more distance. You still need to wear a mask. Outside is better than inside because of the dissipation quickly and the drying of the particles. The case that Sam mentioned was out in Washington State. One of the very first major outbreaks was a church choir that was in a small room, unventilated, low ceiling, and they were singing for over 2 hours. So just the amount of exposure they had to each other. It's really not a matter of the size of the particles or how long they lasted in the air, how long they floated around. It was just the total amount of exposure that people had. That's why they all got sick. So just, use your head. Think about it. There's not a magic formula. You can't look it up in the Betty Cooker's crock book, how far can I stay apart and what kind of mask do I wear? Even in singing, still wear a mask. Cantors, I know our cantor for the high holidays didn't like my suggestion, but I said not only should he wear a mask, but he should turn his back to the audience. He didn't like that very much, but that would have been a good public health measure.
Thank you. Thanks, Murray. We've gotten a question or two as to whether or not we are tonight's presentations, and we are. So for those of you who
I think either you locked up or I locked up, Howard. What was that last
Okay,
part?
I don't know, Sam. I don't know whether Sam heard my
I didn't,
question. Actually, I'll ask you two questions. One that came through, and that was concerning your son, whether he did, how he was doing, and also you mentioned during your initial talk possibility of people recommending that certain maybe over-the-counter medications be kept, with no guarantees, of course, but you did make some comment. I thought maybe I'd ask you that as well.
Sure. As for my son, he was symptomatic. He had terrible muscle pain for about 4 days. Very low grade fever. It subsided in a couple of days. He was kept locked in solitary confinement. Basically, he said that the Navy corpsman would come let him out. They bring him meals 3 times a day, and they let him out for a 20-minute walk on the yard. He said it was like Shawshank Redemption. He said it was completely miserable to be completely isolated. So he's doing well. He's going to go into the submarine service, so he's better get used to small spaces pretty quickly.
Okay.
In terms of what you can take, so looking at the data, let's look at the things that that have been studied pretty well. Let's look at vitamin D. Pretty simple. What the data looks like it's showing in a number of studies, although there's an interesting study that just came out of the UK that may refute this a little bit. The early studies look like if you go into COVID with a vitamin D deficiency, so if you're a vitamin D deficient person and you contract COVID, you will have a much tougher course and a higher mortality. So when you look at supplementation in a lot of those studies, early on, like patient comes to the hospital, we're gonna give them large doses of vitamin D, doesn't really seem to improve the course. So if you go in low, you're not gonna do well. If we give it to you, it doesn't help. However, there's a big study, and I haven't read it completely, out of the United Kingdom, which seems to say that there is some positive effect of taking vitamin D during COVID. I suggest people, particularly, I've been taking vitamin D forever. There's some vague potential that it reduces the risk of getting influenza, and it's been around for a long time. I live in a world of, I have the best suntan fluorescent lighting in an operating room can give you, so I take a couple thousand units, so 1,000 to 2,000 units of vitamin D every day, certainly not going to hurt you. Might help you. As my grandfather said, couldn't hurt you. So I would recommend it. How does exactly does the vitamin D work? Nobody really knows. Probably has some anti-inflammatory properties, lots of things, reasons that it might work, but it's certainly not going to hurt you. Vitamin C, highly recommended. A lot of this comes from vitamin C was used in some studies in sepsis a few years ago where they used hydrocortisone, used a steroid like Decadron, vitamin C and vitamin B1, which is thiamine. And the patients seem to do better. It's a free radical scavenger. It's easily excreted. It's hard to take too much of it because you do excrete it in the urine. When you're under oxidative stress, when your cells are breaking down and you have inflammation going on, it seems to help in that regard. So it's certainly not going to hurt you. I do not recommend taking massive doses. I think the recommendation, you'd have to look, don't hold me to this, I believe the maximum dose is about 2,000 milligrams a day, simply because it will give you predisposition to kidney stones. You'd hate to not get COVID and pass a kidney stone. That wouldn't be a good trade-off, but it's certainly not going to hurt you.
Sounds like you were pushing zinc when you were talking.
Yeah. Well, and I'm not sure exactly why they came up with the dose of zinc. The normal USDA recommendation for zinc is 8 milligrams per day for females and 11 milligrams per day for males. That's what we call elemental zinc. That's zinc, just the zinc ion itself, the zinc metal. When you buy it, you can buy it as zinc citrate, zinc sulfate, methionine, zinc methionine combinations. And their current studies have been using 50 milligrams twice a day of elemental zinc. So 10 times the normal dose, daily dose. Zinc for viruses has been around forever. Cold Ease has made a fortune selling it. When I get a cold, I take it. I do think it possibly shortens the virus in a regular cold. But to get 50 milligrams of elemental zinc, and if you're taking zinc sulfate and you have a 25 milligram capsule, you have to take 220 milligrams because part of it is the sulfate and part of it is the zinc. You get a lot of sulfate, a lot of zinc. So you might be taking 8 or 9 tablets twice a day, and that's a burden for some people. If you want to talk about what zinc does, zinc is kind of interesting. So I've made a couple of notes. I remember one is that it may actually inhibit SARS-CoV RNA polymerase, so it's maybe destructive to the virus, so it inactivates the virus. It also may decrease the activity of this angiotensin converting enzyme 2 receptors, which is, we think, one of the major portals by which the virus enters our cells. It also seems to upregulate or ramp up interferon production, and that can also modulate your T cell function to a certain extent, and they think it may suppress cytokine storm. So not to get off into political things, but the thought about what hydroxychloroquine and chloroquine derivatives do, and there are a lot of different derivatives used around the world now, is that what it is it's an ionophore. It opens, basically, think of it as opening a door or a pore, so that you can take a lot of zinc, but it doesn't really want to go into the cells. And by taking that medication, its activity is not the drug itself, but that it opens this pore, allows high levels of zinc to enter the cells, and then it has these functions of being virucidal, that sort of thing. So it's probably not going to hurt you. I probably take enough zinc. Maybe that's why I am the way I am today. Take enough zinc that I could probably have more zinc in me than an ever-ready battery today. So it's certainly not going to hurt you, and I would supplement myself. Definitely, I think going into this disease, you don't want to really be vitamin deficient. I think that's what we're finding in terms of vitamin D, vitamin C, vitamin B1. Just take a good multivitamin with B. I would take B1 because, since COVID, everybody's sitting at home having a little more cocktail in the afternoon. And the more alcohol you drink, the less vitamin B1 that you absorb. And that's why you get some of these alcoholic syndromes. So it certainly, you can write it off to, hey, I'm having a lot more cocktails. Good idea to take a little B1, might help me with the COVID.
Thanks, Sam. Of course, it worries me if any of us amateurs are out self-diagnosing ourselves and deciding we should take so much zinc or that. I would depend on one's physician to make those decisions, but it's good to know what to have around. We've got a question here about, are there degrees of risk for autoimmune diseases such as Hashimoto's disease?
I don't know that it's been risk stratified. When you read most of the papers, what they'll say is that people with autoimmune diseases seem to be at higher risk. I think my guess would be that Hashimoto's, because it's very specific to the thyroid, is not as systemic as those people who have other systemic or total body immunocompromise in the whole organ system. So I would probably say you're on that spectrum, you would probably be at the low end, but I've never seen anything that really quantifies it. This is an interesting virus, and like I say, it attacks all your endocrine systems. If you thought you were symptomatic, I read a paper, particularly when I was trying to find out about why I was having the sweats in the middle of the night and the cortisol. There's an endocrinologist, one endocrinologist wrote a report and basically said that he's seen all sorts of endocrine problems with individuals with COVID-19, probably because it goes into your brain. And as we all know, when you lose your sense of smell, it's up there and you get your headache, that it probably affects your pituitary and your hypothalamus. And that's where the controlling hormones for a lot of these end organs, like your thyroid and your adrenal glands and those sorts of things, lie. So I think it's quite possible that if you feel like you have some derangement in your normal thyroid levels or something like that, then go see your doctor, for sure.
Thank you. Next question, and I'm going to try to move us along. We promised people about an hour presentation, and I don't want to keep anybody from their appointed cocktail hour or anything of that sort. We've got a good question here, though, from a person who is a volunteer in a NIC unit at Children's Hospital. And the person asked, when I return to that volunteer work, what extra precautions should I exercise with the babies?
I think scrupulous hand washing. One, if you're symptomatic, if you have any reason to believe that you are carrying the virus, even a mild symptom that you may not think is COVID and is out of the ordinary for you, then I would delay, get yourself tested, or go seek a physician who will examine you and make a decision about whether you think you should be tested. Two, I would use normal mask protection and that sort of thing, and scrupulous hand washing. When volunteers come, they like to feed the babies, they're around their mucous membranes, that sort of thing. In terms of kids giving it to kids and adults giving it to kids, there's a lot of interesting studies out there. My opinion is that this is predominantly an adult to child, young child virus. And so there was an interesting study out of Korea a while back, and Murray may be familiar with it, where they wanted to know in the household, who was getting the virus to who? Were kids giving it to adults, adults giving it to kids, or who knows? So in their study, out of every 100 people, 97% of the time, so 97 out of 100 times, they could tell by the order of they at least inferred by the order of symptomatology that the adult had it first and gave it to the child. 2% of the time, they weren't really sure because the symptoms coincided. Couldn't tell whether the chicken or egg. Did the kid have it first or the adult have it? And about 1% of the time, they were pretty sure that the child had it first, and I don't remember the age stratification, how old they were, gave it to the adult. So this seems predominantly the spread is from adult to child, so it is a possibility that you'll give it. That said, the susceptibility of small infants and neonates to the virus is really unknown. It's been reported. I think there's actually a case of maternal transmission. I may be wrong. Is that right, Murray?
Yes.
From mother to baby, but I think it's small. So I would just be scrupulous with your hand washing. Come healthy, wear a mask and your personal protective equipment. It's not as fun to hug a baby when you're wearing all that gear, but it's still very rewarding. Thanks for volunteering.
Thanks. No, thanks, Sam. Murray, a couple of things I might ask you. How, when we see this in news articles once in a while, how reliable do you think that the first vaccines are going to be?
Well, the ones in the US, I mean, we know exactly how the trials are being done in the US. So the US vaccines, you can be you be assured, especially with the latest, as of last week, assurances that the FDA put out for what they will require. I know I'm working a little bit with a German company that's doing a vaccine trial in Panama, which will probably be ready before the ones in the US. I'm gonna have to see the data before I'll decide that, yes, I agree that that's as safe. By and large, the vaccines that are coming from Europe and the United States, you're gonna be able to trust them because we all pretty much have the same kind of protocols for the trials and the safety. First the safety and then the efficacy. I'm going to be suspicious of everything else because of what we've already seen from China and Russia.
Okay, thanks. Great. Very good information. Murray, how about, is there anything in the studies that you have seen that talks about an advantage of a certain type of a diet for a person who is recovering from COVID, or Sam, either one of you, such as a vegetarian diet as opposed to something else? Is there anything that you've seen in that area, either one of you?
Well, that's out of my wheelhouse.
Okay.
I would say, Sam, what did you actually find worked for you?
I would think whatever. If I lost so much weight, it was great. I could eat whatever I wanted to, and chocolate was probably the mainstay of my diet in recovery. But that said, I think any recovery diet, you might ask some people that this is a fatiguing thing that wears you out. I think a really balanced diet is probably the best thing you can have. Adequate proteins, fats, carbohydrates. You might ask some of the sports nutritionists. They might know more than the doctors do in this. One of the things I want to talk about a little bit is, because people are going to ask this question, is can I get it again? And Murray sort of referred to that. Well, yeah, it looks like a few people, it's a very small handful, have gotten it again. I think that they've tested for, I think there are 2 strains now. Murray may know a lot more about how many strains are out there, but it was a different strain. There is a couple that said that they had it once. We're sure they had it. It was actually, I think, a husband and wife physician retirees who said they got it worse the second time. And that's a phenomenon we call enhancement, I think. And so that worries me. If I had it bad this time, what's it going to be like the next time? So there's a lot of good data out there. There's a lot of bad data. Doctors, the thing that's been most impressive about this is, and Murray's probably more impressed than I am, is that from the time we knew what the genome of this virus looked like, we had vaccines in clinical trial in about 6 weeks. I think isn't that right, Murray? And so this is a phenomenal time. We are going to advance vaccine research by decades. I'm convinced of it. And the competition for vaccines, we're going to learn a lot about how to fight these things. Like Murray says, it's not the first, and it's certainly not going to be the last. I am a little bit, so from that standpoint, I'm really elevated about where the state of medical care is and medical science. On the other hand, we've had a lot of really bad research papers. I kind of got caught up in what the media said. Hey, look what this paper says. And when you go back and you really read the paper, I think people would be shocked to find out that so as of September, 33 major publications had to retract their scientific articles because the data was inaccurate, calculations, statistical analysis, the conclusions, something was very wrong in those papers. Some, they can't even verify where the data came from. They just rush to publication. And that's very distressing because the American people really deserve answers. The world deserves answers, and good scientific answers. So I don't want to talk about, unless someone wants to talk about specific drugs and how I feel about them and what the data says. I want to talk about a framework briefly when you're evaluating these kinds of studies, if you're going to read them themselves or ask somebody for an explanation. And that is, when would you expect this drug to work? So if you get the coronavirus, you have about 1 to 5 days incubation period. You're generally can go back to work in about 10 days after that, after your first symptomatology, because after about 7 days, the difficulty culturing the virus. You're not shedding much virus at 7 days for whatever reason. Maybe your own innate immunity. It may be that the virus doesn't find you a good host anymore. It doesn't want to hang around. So drugs that work, when you look at a paper, why would you give a drug that works on viral replication, right? That says, I'm going to stop this virus from reproducing or living inside you, to a patient way down the road when he can't culture any virus from him and is probably in a terrible cytokine storm, immune inflammatory response. You wouldn't expect that drug to work. Vice versa, you may not expect a drug that works on the immune system, right? Later down the road, when you have a big inflammatory process, that may not expect that to help at all during the early viral shedding. So sort of divide these studies up into what we call pre-exposure. There's studies about, should we give you a drug before? If you're in a high-risk hospital worker, should we give you a little of this drug before? Will that keep you from getting it? Or if you've been post-exposed, like, oh no, Aunt May had it and I didn't know it and I got it, what should I take? I don't have any symptoms. And then there's what we call the early studies, early on when the virus is replicating in you, it's spreading in you, it is multiplying in you. And then the late studies when you're hospitalized, maybe intubated, have terrible respiratory issues, organ system issues. So I think what we're going to really learn is that there are drugs that we tried late that may really work early. We tried drugs that work early that vice versa are not going to work late. And I think that when we take 6 months, a year down the road, we're going to go back and look at some of these studies. We're going to redirect our studies. We're going to reanalyze. We're going to do new studies. And I think we'll have a much better handle on what's going to work. And I'm very optimistic about treatment protocols 6 months from now when the politics is done, and about what to take. And I'll be the first one. One thing I do want to say before, I know Howard's going to cut me off here pretty soon because I'm sure we're way over time, is please do not forget that influenza is out there. Lots of things are out there. Please get your flu shot. We don't need a hospital full of COVID patients and influenza patients. Please see your doctor. You know, every month, 40,000 prostate cancers are diagnosed, 40,000 colon cancers are diagnosed, 40,000 breast cancers are diagnosed. Do not delay seeing your physician when you can so that we can make diagnosis. Better to treat those early. We don't want the fallout from how we're dealing with this disease to create a huge problem with other disease states later down the road. Don't forget your general health care, please.
Very good point. Thank you, Sam.
Aaron,
I want to wind up with a couple of things on masks, if I could. I'm sorry, Murray, I didn't mean to interrupt you.
Well, I just want to say very quickly, the business of the twindemic, flu and COVID. One of the really interesting things, it's a data point that we do in predicting how much disease we're going to have, is that the protections against COVID happen to also be very effective protecting against flu. So the Southern Hemisphere has flu during our summer, it's their winter. And we look at, for instance, what went on in India and Australia summer to predict what we're going to have here, and even to pick which strains of influenza to put in the vaccine. They had a really mild flu season in the Southern Hemisphere because everybody was doing vigilant hand washing, masks, distancing, etc. Now, hand washing is even more important in influenza because it is a major way of transmission that it gets on surfaces, stays there, and is picked up on your hands and then put in your face. That is a method of transmission of COVID, but not a major one. So there's all kinds of reasons to other than just being afraid of COVID or trying to stay away from COVID, to just do these good health practices, and particularly now coming in with influenza. I also wanted to comment on what I called CNN-itis. One of the reasons, I really don't blame science so much as I blame the media here. Science is happening, as Sam said, at an unbelievably rapid pace now, because it has to be. It doesn't mean that there's a lot of bad science. What's happened is that our usual methods of taking time to peer review articles, to go back and forth, to review data, share data, that's been very much truncated because of the internet age. And there's a phenomenon now called pre-publication. And there are medical pre-publication journals, if you will, that readily admit this is a pre-publication. This is a draft. It's come in, we think it's interesting, we're putting it out there because we want the scientific community to weigh in. We want to see who's doing similar work. Can we get to conclusions faster by sharing this now? But those get into the media and they have some spectacular story of, oh, there was this report of, such and such, and everybody goes nuts. And that's what I call CNN-itis. Basically, I recommend turning off your television. If you really want to follow these kind of studies, it's not what you're going to see in the media, it's what you're going to read. Even reading newspapers is usually better than TV. But stay towards some of, even Scientific American is a perfectly good example. A very nice consumer-oriented kind of a magazine that has very up-to-date information, and it puts it on an even keel. What's really happening? What do we just think is happening?
Let me ask you, thank you very much, Mario. Let me just ask you and maybe conclude, because time being what it is, a few things, let you kind of pick and choose on these mask-related questions. We had a person ask, comment, I should say, that they've seen people working in stores with just these face shields and no mask under the shield. Is it your opinion that that should be allowed? That's one question. I also want to know whether or not these, and I think they're pronounced HEAP filters that are in some masks are of value. And then finally, your thought on people going into restaurants where, obviously you can't keep the mask on, while you're eating, but do you have any feelings about how long, you can stay in a restaurant without a mask? I suppose it has something to do with where you're sitting and who's near you and all these things, but those are a kind of a group of mask related questions that I'd like to kind of get your thoughts on, Murray, if I could. And then unfortunately, probably going to have to start winding up, but I'd like to get your feelings on those things.
Sure thing. Face shields are pretty much okay to protect you from somebody else most of the time. They're not very good protecting other people from you. It's not like these particles are going to swim or float or go underneath them, et cetera. It's just that they're not stopped. They're this many inches in front of your nose or mouth, whereas a mask is right there. So it just has more space to circulate.
So my favorite coach, Andy Reid of the Kansas City Chiefs, with his face plastic shield, is not necessarily the best thing for the players around him, if he doesn't have the mask underneath it.
That's correct.
Okay.
Other people
I didn't mean to interrupt you.
Well, when you talk about having a face shield and a mask, which I do in airplanes, when you know you're going to have confined space around people, that's sort of called the belt and suspenders approach. You're not going to lose your pants, so you put them both there. More protection is better. Face shields, by and large, to me, are more comfortable than most masks. So if for any reason, plus people get irritations on their face from masks, etc. So it's better than nothing. Actually, having a Kleenex over your mouth and nose is better than nothing. As I said, any kind of mask, any kind of barrier. I think that if we inevitably get to some sort of mask mandates, whatever that's going to mean, face shields alone probably will not be allowed. You're going to have to also have a mask because you're worried about fit. You're worried about gaps under the chin, on the sides of the face, and around the nose because air is going to leak out, and so will all the virus. HEPA filters. We talk about N95 masks. And essentially, those are HEPA filters, high efficiency particulate filters. something that's on the market that I find really useful. You can buy these little, essentially it's like a sheet of HEPA, and you can cut it, or they come pre-cut in little trapezoids or whatever. And then you can put it between the two layers of a cloth mask. Very comfortable, very easy to clean, put them in and out. And that's going to give you terrific protection. Essentially, it's giving you the same protection as an N95, which N95s were specifically designed for hospital workers. They're the most protective, highest protection factor of a disposable mask that you can get. Part of the problem early on certainly was that we didn't have enough for our healthcare workers. And so we needed to keep them away from the general public so that we have enough supply. I mean, there's a lot of lawsuits going on now, and a number of deaths and wrongful death suits in the Northeast from nurses in particular that had to wear the same mask over and over and over and over for weeks or months. And that's doing no good. All that's doing is concentrating the contaminants to make them even, breathe it more so. But HEPAs are good. If you can get, an N90, right now N95 still I think are pretty scarce. They're also hard to breathe through, and they're hot, so they're not real comfortable. So unless you're going to be like a healthcare worker, you're going to be in an area with high virus, and you're going to be close to people, and you're going to be there a lot of hours, that's when you need an N95. If you want to go on the internet or go to some of these stores and buy these little HEPA filter, well, I guess they just call them filters, or disposable filters that fit inside the mask, highly recommended. In terms of restaurants, there's a whole concept in public health called relative risk. And so you have to weigh all of the factors. For example, I'm 69 years old. I have all of the risk factors for the highest possible risk for COVID. So I'm going to be much more judicious about where I go in the public. I haven't been in a restaurant in 7 months. I don't know when I'm going to go again. I've come to really enjoy these deliveries. Nice idea. We wish we had those before. So that's me, because the relative risk, irrespective of the distance and the ventilation and the indoor and the outdoor and the sunlight, I still know I'm the highest risk. So I have to make a decision based on that. And I would recommend everybody, just get smart, just understand what's happening. Again, you're not going to read a recipe in a book. Here's what I can do and here's what I can't do. Understand what's happening, how the virus, as we learn more, how it's acting, and then just try to avoid it. I mean, Sam gave the best example I have heard yet of why you don't want to get this virus. It's like these crazy kids that have these infection parties or whatever, because they say, oh, if we'll just get infected now, then we'll be immune. Well, A, we don't know that they're going to be immune. B, we don't know what kind of sequelae they're going to have for the rest of their lives. What we do know is it's a bad idea. So unless you want to end up like Sam was describing, don't get the virus. Stay away from it. That includes in restaurants. By the way, I love restaurants. I love bars. I'm sorry that so many of them are closing down, but it's not because I'm not going. It has to be a lot of other people aren't going.
Thank you. I want to thank both Dr. Sam Kleinman, Dr. Murray Cohen, for just an absolutely enlightening presentation this evening. Cannot thank you enough. And I want to also thank all of you who are listening to this presentation on this Zoom, this webinar. It has been our pleasure to at the Federation to partner in on this function this evening. And as I mentioned earlier, it has been recorded, and we'll hopefully be able to make it available to those who want to. Some questions I've got, people want to listen to it again, compliment to our speakers, and certainly many people who were unfortunately not able to join us tonight. But I want to thank everybody for attending. Have a pleasant evening and stay safe.